Okay, hello everybody, and welcome to Wednesday's Weekly. This is your briefing, your bite-sized briefing, a collaboration between Action Together, the voluntary community faith sector, and the public sector. So really pleased to welcome you. This is our first cost of living crisis series, Wednesday's Weekly of 2023. So very welcome, very good to have you here. We're working with Oldham Council to welcome you every Wednesday between now and next April or this April, to hear from services and organisations that are working alongside you in Oldham, delivering really critical help to support Oldham residents through the cost of living crisis. Without further ado, I'm really pleased to hand you over to Julian from Turning Point, who's going to take us through today. Over to you, Julian.
Hi, nice to meet you all. So my name is Julian Cohen. If we go on to this slide, a little bit about Turning Point. We're one of the leading social enterprise agencies providing health social care services across England. The good thing around our governance is we support people around health and well-being, but we work with people with mental health, we work with people with learning disabilities, and we work with substance misuse services. So it means from a head office point of view, they can get all the expertise between all the different parts and join it up together, which is really useful. So within Rochdale and Oldham, we've actually, the service is called Rochdale and Oldham Active Recovery. I am actually a community development worker. I've put my email address because I know we're going to have sort of questions on here, but it might be that people have individual questions or something they want to raise direct with myself and not put it on here. So it's julian.cohen@turning-point.co.uk. So if people do want to email me, you've got my email address. Thank you. Next slide, please. So in terms of Rochdale and Oldham, we've been commissioned, and it's 18 plus upwards for drug and alcohol treatment for both boroughs. The reason they commissioned Rochdale and Oldham together was the profile of the community is quite similar in terms of key areas, high deprivation, and also in terms of particularly heroin use. It tends to be an older cohort of people that tend to use and use for longer than possibly other areas. So they're aging. With aging comes extra comorbidities. We also historically I think if we go back to particularly Oldham, it was a bit of a party capital back in the 70s and 80s. It was a place where people used to come. The fallout from that is we have a lot of older clients who get referred into treatment possibly a little bit too late. They've not had any formal treatment, but they come to us extremely either end of life or just extremely unwell with the whole complexities of alcohol problems. What we do is we do different types of interventions. So it can be just early intervention, support, advice and information. We're very much around recognising that not everybody wants to stop using substances, alcohol or drugs. They may want to reduce, they may want to find out what they can do. So we do offer what we call harm reduction. So it's recognising they're going to use, but what we want to do is make sure they do it as safe as possible. All the treatment we do is structured around an evidence-based clinical and psychosocial model. And we do employ quite a lot of suitable trained clinical staff, which is led by a consultant psychiatrist. He oversees that team, and then there's a number of different nurses and healthcare assistants as well, because it's all about recognising that the people we work with are some of the people that present with the most risks. So it's ensuring that we can sort of, I suppose, really tick every box. We're trying to keep people as safe as possible. We also know over the past 12 years with the difficulties of austerity that the clients as well that need the most healthcare, they have the most healthcare needs, tend to get the least healthcare due to the fact that lack of engagement, due to the fact that the thresholds for getting into services are really difficult, and also the fact a lot of services won't work for clients whilst they're actively using. We have a clear defined pathway which is looking straight into the service at assessment, and we're very much talked about recovery from the day that people come in, whatever the recovery is of that individual, what they expect it to be. But we follow them all the way through and get them into an aftercare recovery. We have the 2 services at 5 Grieve Street, which is back of the town hall in Oldham, and we also have one in the centre of Rochdale by St Chad's Church. We also cascade ourselves out into community centres and GP surgeries. We recognise that not everybody wants to come in to a formal alcohol drug treatment service. We also recognise different BME communities, LGBTQIA plus communities. They may find it not the place to come to in the centre. So we'll work in a person-centred way according to need. And it's around connecting care to help individuals meet aspired goals. When I say that a lot of our clients don't always get the full healthcare services that they need, we are there to be that conduit to help and provide and support for connected care. Thank you. The treatment challenge around alcohol is, we know that in England there's an estimated 602,391 dependent drinkers. Now that was in 2018 and 19. We know with COVID that has increased. So during COVID, we had about 20–30% increase in drinkers, but majority of those, as we've moved out of COVID, are not actually classed as dependents anymore. They've gone back to being either safe and sensible social drinkers, or they've stopped drinking. But COVID did present an issue. We do know in the UK, alcohol misuse is the biggest risk factor for death, ill health and disability between 15 to 49-year-olds in the UK. It's the 5th biggest risk factor across all ages. So we're talking about things like heart problems, high blood pressure, liver issues, kidney issues, all the parameters of early onset ill health. Alcohol can be a key indicator. 7 types of cancer are linked to alcohol. 24% of adults actually are drinking regularly beyond safe drinking levels. An unmet need for alcohol treatment in Rochdale is at 78%. So we know, and that's 82% nationally as well, that actually there's a lot of people that don't actually ever get to treatment that are drinking in excess of safe drinking levels. And of course, that puts an extra burden on our healthcare systems, hospital, GPs, and other services as well. The worrying sign is 2020, we've got increases of alcohol-specific deaths, and it's a 20% increase compared to 2019. We're looking at the problem with that is in the most deprived group, we're seeing higher rates of deaths. And also we've got to look at the alcohol being a depressant, that mental behavioural disorders due to alcohol have also seen quite an increase. Deaths from alcohol poisoning is a worry because that can be around younger people as well, but we've seen increases in that as well. So the concern is that alcohol is a challenge. Next slide. When I say alcohol is a challenge, it's just a quick slide, and this is one for extra support and training if people want it, is which I do offer from Turning Point specifically around all the different substances that we work with. The body map very clearly shows that alcohol affects every single organ of the body. We look at things like all the way up to alcohol-related dementias, but there's nothing that escapes alcohol. So that's why it's so important that we can get effective good treatment. And I think the important thing to understand is to get treatment as early as possible for the individual. Next slide. We then look at the drugs, and 2.1% of adults 16 to 59 are classed as frequent drug users. So it doesn't sound too high. There'll be a lot more people using drugs. That's what we're classing as frequent. Again, we look at areas of higher deprivation, 16 to 24-year-olds particularly. I think when we look at Oldham Rochdale, the majority of drug use in that age group is cannabis, although we're looking at things like nitrous oxide also presenting as problems. We're looking at nitrous oxide in BME groups, particularly young males, and that can also present issues around early onset disability or even coma and death from the nitrous oxide. Cannabis, we sometimes, not for everyone, but we see increases in exacerbation of psychosis and mental health from the particular skunk cannabis. We also recognise as a service that, like most drinkers, most drug users do not develop serious problems. So our early intervention, we work closely with Early Break, the Young People Service, is that actually good, robust, strong advice and information to help people weigh up pros and cons of what they do can be really helpful if you start at a young age. We do see serious problems develop from a number of different things that combine, and it's a tinderbox: poverty, trauma, stress, isolation, mental ill health, bereavement, unemployment, homelessness, experience of abuse, and adverse childhood experiences. All those things add together create a tinderbox, which can lead to addiction, dependency, and we do recognise that reaction to life events. So what do we look at? Mental health. We've got a new mental health nurse practitioner because we're looking at 76% of clients that start treatment have a mental health need. So with the national pictures 59%, we're looking at Rochdale and Oldham being higher. What I said before was the alcohol clients presenting later than elsewhere, with high levels of independence and complex physical mental health conditions. If someone comes at late stage, it's quite hard. The disease model of addiction will look at alcohol being a disease, but what I can clearly say is the longer people have been drinking and the more ill health they've got, the harder it is to deal with the issue. Our opiate using population is largely older. Many are treated and achieve stability, but we also, and very much around that old cohort, as they become quite entrenched, but they also may be on substitute prescribing, but may use on top. When we look at cost of living crisis, it's interesting because I've just had a call from someone from housing to say they've got a couple, they are on treatment, they are on a script, so the idea is they don't need to use illicits, but the fact that they use illicits on top takes quite a proportion of their benefits, which means in return they can't spend money to heat the house, which in return has led to the house being having mold and damp. And the struggle is to get into the house to support them. So again, this cost of living crisis for people not having enough money to pay for the drugs, to pay for heating, to pay for food is a challenge. Combinations of drugs, we know there's an issue around people mixing drugs. We have had deaths in Oldham through people buying illicit diazepam, fake Valium from the Cheetham Hill area, and that's something that's being dealt with from the police, which is good. Next slide. Why do people not stop? This is quite simple. We get a lot of referrals into the service. It's in excess of hundreds. I couldn't tell you the exact amount, but we get referrals from social services, we get from family, we get referrals from everywhere. But the cycle of change is something quickly to look at. When people are ready to make change or are determined to do something about their addiction, it tends to be a successful treatment program. But we do recognise rates of relapse are high with all types of addiction. Majority smoking, people can go around that cycle of change between 10 to 20 times. What we do recognise is the good thing is people learn along the way. But if people are not interested in changing what they're doing, it tends to make the process difficult. So it's just an idea of why people don't always engage with us. Okay, next slide. So the harm reduction part of what we do, we want to support each client to be safe. We recognise not everyone wants to stop. There is no way of using alcohol or illicit drugs safely. We recognise illicits. People don't know what they're taking. The supply of drugs changes, the quality and purity changes, but we can absolutely all together do more and more to try and support people to be safer. And it's not just us, it's the communities that people use and live in, and that happens informally. People check on the neighbours, people make food for the neighbours, people check that they're all right, their health's all right, just knocking on the door. So we have good, strong, the good thing about Oldham and Rochdale is we have good, strong communities. Advice and information is critical at early stages based on evidence, and we motivate people to push them around that cycle of change, which is important. Thank you. Next slide. Just a couple of things that we've got. We do have our needle exchange within our service. Anyone can come in and get clean works. We make sure they've got clean needles. We give out sharp spins. We have something called Nixoid, which is in the left corner, which is a nasal spray. That will take people out of overdose situations. And we have something called naloxone in the yellow packet there. Those are critically important, and it's important that everybody knows that we can prevent opiate-related deaths. Opiates slow down central nervous system, they slow down brain activity, and they slow down breathing. They lower blood pressure and lower heart rate. So when people take an opiate, they are at risk of overdose and death. So that overdose kit will literally bring them round straight away, enough time to get them to hospital. We also give lot boxes, which are really important because the idea is, as well as methadone, if people are on methadone, methadone is highly poisonous to children. So it's around making sure we not just keep the individual safe, but also children as well. We also as well will give information around drink and drug driving, and all the whole lot is just a combination of safety. Next slide. So what do we do on assessment? On receipt of assessment, we complete an initial triage, and we then book them in for a comprehensive assessment. The assessment is really in depth. For high-risk groups, we have priority assessment slots, but it takes quite the comprehensive assessment will cover everything. It'll cover their healthcare needs, what they're using, safeguarding issues, what they want, what their aspirations and goals are. We'll do full risk assessments, and it is all around looking at each individual in a person-centered way. We have rapid referral for nursing assessments to assess physical mental health, and any necessary interventions are done, and referrals to our partner agencies. We conduct care plans regularly, risk assessments are part of that, and they're reviewed on a 12-weekly basis. Any medical assessment and prescribing is initiated as soon as it's possibly safe to do so. Because what we recognise is if someone is using street drugs, particularly heroin, the sooner we initiate prescribing, that lowers the necessary risks. I suppose again, with addiction, people can be quite sometimes chaotic, but if they don't attend initial assessments, further appointments are offered, and then we have attempts made to contact clients by other means, which includes letters, outreach, and also connecting with the partner agencies that are preferred to pass that information on. Next slide. So who can refer? Well, anyone can refer. Referrals from individuals themselves, but referrals can come as long as there's been consent from that person. If the client's not consented, they're unlikely to believe that they've got a problem or engage. We know that people in addiction as well, whatever type of addiction, whether it's gambling, whether it's smoking, most of the time whilst they're in active addiction, tend to be in denial of the issues and concerns that addiction is causing. So we do recognise that, but around there is work that can be done around motivation before referring client in. We also look around what's going on for that individual, what that drug or alcohol is causing, whether it's health problems, relationship issues, or actually sometimes we get around their involvement with criminal justice system. If pre-work can be done, all the better. And that could be just like a simple questions like, how do you think your substance use impacts on health, relationships, behaviour? Would you like to discuss this with someone who could help you make changes? So it's just like simple questions that you just need brief advice and information. Within our own teams, it's broken down into criminal justice. Now, people that go through criminal justice could have what we call treatment requirements where they have to actually engage with us. We have HAT, which is our homeless treatment prevention service, and working with the homeless, give that extra support and help. Our young persons worker is 18 to 25, and the young persons workers recognise that different types of models of support are needed. Recently, our young persons worker has done a course called Minis. So where parents have had their children removed, recognising that if someone's children are removed because of their drug or alcohol use, that could cause extra trauma, which means their drug use could spiral. So it's that extra support, mothers in need of information and support group. I do family carer support, which is a 5-step group. We have our own aftercare recovery, and we do building on our strengths together. We're adding more things to our aftercare recovery offer. We do mood management, mindfulness-based relapse prevention, and we do something called self-management recovery training, which is a mutual aid support, which is another offer, as well as our fellowship AANACA workshops. Our safeguarding specialist lead is there to oversee safeguarding and to keep people safe. Our workforce development manager looks at making sure our whole workforce team is equipped to be able to work to the best possible standards. Within community development, we have community assets funds for recovery. So if we have services, we can support them if they can offer something for recovery for their own community. So we have Flourish Fund, which is 25 quid for our own clients to help them for something. We have £200 to help them if they have an idea which they can put into practice. And for partner agencies, we have individual slots of £1,000. We have a volunteer coordinator who runs our volunteer programme. And also we have volunteers help and support our service, and also around making sure that when we're any innovation or anything that's happened, and that we ensure we have co-production at all levels. The clinical team is led by a consultant, nurse medical prescribers, and healthcare assistants. Education, training and employment's part of it. And our new IPS workers are brilliant because they're now finding placements for anybody with addictions. Psychosocial intervention team provides group work for clients to be able to connect and to support each other for their journey of treatment. We do prescribe. We look at the different type of drugs and alcohol. So we break it down into non-dependent substances and dependent substances. Dependent substances produce more risks because of withdrawal. So for heroin, we have offers of methadone, buprenorphine, which most people know as Subutex. The game changer for heroin and any opiate addiction is something called Buvidal. Now, Buvidal is a slow-release, long-acting Subutex injection, and it's administered by our own nursing staff on a weekly or monthly basis. And that means that the client doesn't have to go to pharmacy to have supervised consumption. And it's also Subutex buprenorphine actually has a blocker in, so if people try to use heroin, it means that the heroin, there's no point in using heroin. But what we do is we give people a choice around what type of medication they would like as an option instead of using street heroin. The biggest single way for harm reduction and safety is to hopefully support and initiate a substitute prescription as soon as possible. The aim of treatment for the client is to reduce and stop illicit use, and we do want to support people to detox and long-term abstinence. There's no set timescale for clients to achieve this. With alcohol, we recognise that if people are dependent, again, it presents the most risk. So we have reduction programs, we have detox, and we also have aftercare, and we can give medication to support for cravings. Next slide. Residential detox rehab. There's not a huge budget for this, but we can look at helping support people for detox. We have our partner agency, Smithfield, where we can send people quickly. But we also have residential rehab, and there's panels who make decisions based on assessment and applications made by nurses and recovery workers. Inpatient detox for alcohol is usually 7 to 10 days. For more complex people, we'd be looking a little bit longer and also using Chapman-Barkey unit. For opiates, we can look at 4 to 6 weeks, although the majority of opiate detoxes can be initiated in the community. Residential rehab is longer, and that involves a stay at approved providers for up to 16 weeks. So the idea of access to inpatient units is overseen by panels, and they assess, I suppose, really making sure someone's motivated. Do people want to change? Do people want to go to residential? Do people want to connect with others? And are people going to be ensured that they're going to stay abstinent when they leave? So I think that's a challenge. So beyond treatment, where do we go after treatment? We're working very closely with partner agencies and the growing population of people with lived experience of recovery. So we want to build visible activities and groups, as well as promoting access to mutual aid, NA, AA, CA, and smart recovery. We really want to get people to use the support that they can find in their own communities. It works best when they take ownership of their journey. Action Together, again, all the courses that we get sent and all the groups that are involved in the Action Together network and supporting people is really important. That asset-based model of recovery is the most effective. Our peer mentors support and help people. With former users, we can get involved in voluntary roles. Most of the workers recently who've been employed have come through that programme. We work with partner agencies and we refer to partner agencies. If someone disengages, we're very, it's around re-engagement through outreach or ensuring that we liaise with the partner agencies to see how we can re-engage. If we do have to close a file, we notify the partner agencies and they can re-refer if necessary. What's important to know is repeat alcohol detoxes are closely reviewed, because continual alcohol detoxes can be counterproductive for a journey of recovery, and it also increases risks. That's sort of like a very fast sort of resume of what we offer as a service. That the web page that we've got there for Rochdale and Oldham is that's our link. And on that web page is something called self-help section. On the self-help section, there's different bits around each specific drug, what the drug looks like, what the risks are, why people use it, and how to support the minimisation of risks of that drug. And the phone number is 0300 555 0234. Thank you very much.
That's wonderful. Thank you so much, Julian. Wow, my mind's blown. So much information there. Thank you. Really, really helpful.